Hi, Melanie, and hello, everyone. I'm going to give just a couple more minutes while people filter into the room before I start formal introductions. But I will be actually starting the content of my talk by 10:40. And just to introduce myself, I am Miles Rogish. I am the consultant neuropsychologist at York House.
And
I'll let Thomas introduce himself.
I'm Dr. Thomas Olympia, consultant psychiatrist at York House. So thank you for being here, and I hope we have a good, entertaining, as well as sort of quite informative discussions today.
Thanks, Thomas. And yeah, if anyone wants to say anything in the chat, I will be seeing that. If you have, I'll go ahead and start with the preliminary. This is how I'm going to do this webinar kind of discussion. Now, I, we've been dealing with the pandemic for a year now. I think everyone is getting kind of used to this online learning platform. We do a yearly seminar at York House every year, just as part of showing what we're doing well, giving the people, our stakeholders, information on developments and research going on at York House. What we decided to do for the webinar version instead of the seminar version is to keep it very short and concise. And, unfortunately, we don't have the time to network and really get to talk socially, which is always my favorite part of the seminars. So today you'll just get me and Thomas talking about some of the research and service development issues that are currently being conducted in our service. I will be speaking first, and I will be speaking on some research that I've recently conducted at York House. The research that I am conducting does stem from the new model development that Thomas will then be speaking about in detail once I've completed my talk. Hi, Laura. I not got an error message. No, other people don't either. So it might be, yeah, doesn't look like anyone else is getting an error message. So often these things happen with these webinars as individuals might have some difficulties with connectivity. I will say, if any of you experience difficulties or you need to pop off for any reason, this whole webinar is being recorded, and it will be uploaded to the YouTube channel, the Disabilities Trust YouTube channel. So you can review this later if you need to. For those of you having the connection issue, are you able to see the slides, and are you able to hear me okay? Okay. Then okay, well then if you can hear what I'm saying and you can see the slides, then that works fine for me. Now, today's webinar, we're going to have two talks. The first talk will be by myself, and it will be on the use of compassion-focused therapy-informed formulation for staff support. The second talk will be by Thomas, and that will be the Neuropsychiatry Plus model, which is the model that is under development at York House. I will be trying to keep track of my timing pretty well. My talk will be about a half hour. Thomas's will be slightly longer. We will finish for Q&A at about 11:45. We will then have Q&A, and the questions can be put into the chat window. If you have any questions, please feel free to ask as we go, but we might not answer while we're talking. We might hold questions till the end. We do have an admin person online who will be organizing and noting any questions you have, so hopefully we won't miss any questions from anyone. And it's almost time for me to get started, but I am going to give it just a couple more minutes before I actually start my talk, just so that everyone has a chance to get on who wants to. And yeah, last thing I'm saying, like I said, this is a webinar. We've kept it short, so we're not planning any breaks for the next hour and a half. Again, if you need to take a break, take a break. This will be recorded, and yeah, if you hear a fire alarm, please go. We won't be having a fire alarm here, but you all will, if you have one, of course, just go. So what I'm going to do is I'm going to go ahead and get started with my part of the talk. And if you have, like I said, if you have any questions, please pop them up in the window. So the title of my talk is The Use of Compassion-Focused Therapy Informed Formulation for Staff Support. In this talk, I'm going to discuss some unique work that I have done at York House to try and pioneer the integration of compassion-focused therapy work within a neurobehavioral population and for people with profound challenging behavior. I need to do a very special thanks to Ms. Brogan-Kerr and Emma Bonnick. They are master's students who did this research with me last year as part of their master's work at the University of York. I work as the consultant at York House 3 days a week, and 2 days a week I teach on a master's program at the university in development disorders and clinical practice. The master's students doing this research, they were brilliant, and we are currently in the process of trying to get this work published. This is actually the first time I'm presenting this information, so please feel free to ask questions, and hopefully we will get some good discussion out of this. So, the objectives for my part of the talk. I am going to give a very brief overview of compassion-focused therapy. I'm not going to go into a ton of detail on this simply because I want to keep this talk relatively focused, and while I am trained in compassion-focused therapy and I really enjoy it as a therapeutic tool, the focus of the talk is going to be on more than just CFT. And I'm also going to review the recent research that we have done to investigate the effectiveness of this integrative approach in staff support. Now, I'm going to start off by just briefly discussing what is psychological formulation. Now, I'm assuming there are quite a few psychologists in the audience, so I'm sorry if I'm preaching to the converted, but for the non-psychologists, psychological formulation is a method by which the development and the maintenance of a psychological or a behavioral difficulty is described. Now, formulations can be done from a variety of different therapeutic or clinical models. You can have cognitive behavioral formulations, you can have psychodynamic formulations, and how a different school of thought would formulate a problem will vary. Formulations also typically include intervention points based on the theory that the formulation is developed from. So a cognitive behavioral formulation might have specific cognitively based interventions or behavioral interventions to target the problem. The talk that I'm giving, the formulation that I'm going to be using is actually an integrated formulation that will include both compassion-focused therapy information and ideas, as well as neurobehavioral formulation. I'm going to go into that in quite a bit of detail. Now, I do like to also start off with just a definition of what is compassion. The definition that I'm giving is by Professor Paul Gilbert, who's the founder of the School of Compassion-Focused Work. Compassion is being moved by the suffering in another and being motivated to alleviate it. Okay? And when it comes to the feeling of compassion for another, there are 3 components to this. There is an affective component, and a way to describe that is I feel for you, I feel for the situation you are in. A cognitive component, I understand what's going on with you, I understand what you are thinking, and also I understand the details and the situation that you find yourself in. And then finally, there's the motivational component. which is about being motivated to move toward the suffering in another. Yeah, in general, people, when we see distress or we see problems, we often want to avoid that. No one wants to actively approach someone who is suffering, just as a general rule in human behavior. However, the school of compassion focused therapy points out that to be compassionate for another, you actually have to have motivation to help that person, which means actually moving toward the suffering. Now, again, compassion focused therapy developed by Professor Paul Gilbert. It is a form of therapy that is grounded in basic evolutionary concepts and also social motivational systems. It also integrates a lot of different schools of thought, everything from some Buddhist beliefs of mindfulness to actually attachment theory. So it's a very complex theory that is grounded in evolutionary and neurosciences, but it also very much speaks to the human experience. It's not purely technical. It is also very much a way of working with someone where you do focus on the feelings of the individual. Why did I find a compassion focus of interest, or why did I try to integrate this into the work that we do at York House? Well, first off, York House is an environment where our service users exhibit challenging behavior. And that being said, there is some degree of risk in work. The probability of you being verbally assaulted is common. The probability of you having a physically directed incident directed at you is also possible. So the work we do at York House does have some degree of threat for staff. Also, people with chronic problems often come from very difficult backgrounds. Now, these difficult backgrounds can be associated with a high degree of shame and self-criticism and self-dislike or self-loathing. CFT has been shown that it is a very good therapeutic technique for helping individuals deal with their own issues of shame. Many of the service users at York House have pre-existing conditions prior to a brain injury, and this includes people with attachment difficulties, significant substance abuse histories, and psychiatric diagnoses. Again, Thomas is going to go into this in a bit more detail when we talk about why we have developed this new model, but I think it's important to point out that the use of a compassion-focused approach being integrated into multiple aspects of the work we do at York House is one of the ways we are trying to address the complexity of this population. I find a compassionate focus important also because we live in a world of internal and external threat. And for many of our service users at York House, few of them have had consistent experiences of feeling safe or feeling soothed, and almost all of them find it very difficult, if not impossible, to soothe or calm themselves. So, a service user might be able to understand the logic of an intervention or a discussion around emotions and the complexities of it, but then they can't take that logic and apply it to themselves or apply it to their own emotions in the moment. Again, a compassion approach helps us understand how to work with these individuals. Now, there are a few different ways to formulate within a compassion-focused therapy model. This is the aspect of formulation that I used for this particular study. Now, this is called the three-circle model, and this is a model used in CFT to try and describe our affect regulation systems. So how our body-mind connection will naturally try to find some form of emotional or affective homeostasis. Okay. Now, going back into the evolutionary aspects of CFT, the old brain part of the slide below, the threat circle and the drive circle. And the threat circle, the red circle, drive circle, the blue circle. All of these systems are in every vertebrate. from reptiles to mammals, we all perceive threat. We all have a fight or flight response built in, and there are both neurochemical as well as brain structures that are specifically uh, utilized to recognize threat and to upregulate and downregulate different systems to deal with perceived threat. Also, all vertebrates have a drive system. Okay? A drive system is more than just a reward system. It is a system by which we energize ourselves to find the aspects in the environment that we need to survive. So drives can be very basic, like hunger and thirst. Drives can be for procreation. So the sex drive, all of these are basic drives that all animals have in order to maintain life. Okay? Now, as evolution has occurred, with the little graphic to the side, you see that as we move into more complex animals, and in particular, as we move to mammals, mammals have some very different aspects to their affect regulation, and mammals have specific attachment and soothing abilities that develop through the attachment of typically the mother or the primary carer to the child. The ability to soothe oneself is developed in humans based on the original attachment of the mother to the child. So the child learns to soothe, that the mother is a soothing object, and by learning that, the child learns self-soothing. Now, in humans, we have all three of these systems working together. And ideally, the way this model is describing, we would hope that these are in balance. So none of the circles overtake the other. We are able to soothe, but we also are able to react to threats and then soothe from the threat. We have drives that keep us going and keep us motivated, but those drives never overtake our ability to self-soothe. And those drives also are checked by threats, so we don't put ourselves in risky situations to satisfy drives. Again, that is how a system in balance works. That's an important point, and I'm going to be coming back to this point when I present the formulation of the service user that we used in this study in just a few slides. Now, that was the compassion-focused therapy aspect. Now, what about the neurobehavioral model? Okay, well, the neurobehavioral model is the overarching model at York House. Sometimes I describe it as the backbone of how we work. The neurobehavioral model develops everyday life skills and adaptive social behavior. And the aim of this model is just to try and get people better integrated socially and reduce social disability. This model works through the process of repetition, feedback, and reinforced behaviors. It works through procedural learning, not through explicit learning. And because of that, it bypasses memory difficulties that are so common in individuals with acquired brain injury. That is why this model was developed. It was developed for individuals who might have difficulties with explicit learning, but still have the ability to acquire new skills. So it is social skills-based learning in an indirect route that does not require explicit memory. And it involves those more older aspects of the brain, which are, again, more resilient to damage and more resilient after an acquired brain injury. Now, one other part of the neurobehavioral model that I think is important, staff and the environment within a neurobehavioral setting act as an external manager of behavior. I like to sometimes say that the unit is like an external frontal lobe for our service users. And it is through consistency, both within staff and within the environment, that the individual with the acquired brain injury is better able to, again, consistently practice appropriate social interactions and develop better social skills and reduce social disability. Now, again, I'm assuming in this audience, everyone is going to know this, but one of the primary deficits in individuals with acquired brain injury is a dysexecutive syndrome. And briefly defined, a dysexecutive syndrome is a difficulty controlling or monitoring your own emotions or your cognitive functions. Also, challenging behavior is common in individuals with ABI, and well, this is a challenging behavior environment. So all of our service users have challenging behavior to some degree. A challenging behavior can be defined as any any behavior that makes it difficult for a person to use regular community facilities, or a behavior that might put themselves or others at risk. And again, this is a wide range of behaviors. It can range from over aggression to a lack of engagement. And so the definition of what is a challenging behavior is appropriately quite wide. Now, neurobehavioral formulation will describe how changes in the brain because of some acquired brain injury will lead to either a dysexecutive syndrome or other associated behaviors that make it difficult for that person to fulfill the social roles they might have previously had and to live independently. So there's a really nice linkage here between the CFT model and the neurobehavioral model. It is clear that the neurobehavioral model works well with individuals with acquired brain injury and dysexecutive syndromes. This has been shown in the literature numerous times over decades. The CFT model, in particular the three-circle formulation, looks at aiming to balance an individual's affect and motivation systems. And it's a key way of formulating someone's presentation. You can link these two theories with an emphasis on the emotions of the service user with the dysexecutive syndrome. And it also informs and kind of normalizes the emotional reactions in the service user, as well as in the staff members who might be at the receiving end of challenging behavior. So what did we do? Now, first off, I did allude, we have integrated CFT into many aspects of training at York House. So with my staff who partook in this study, all of them had had some degree of CFT information before, not formal training. Okay. But what we did in this study is, in order to evaluate the impact of CFT informed formulation on staff support and staff ability to manage challenging behavior, we used a method called Interpretive Phenomenological Analysis, or IPA. IPA is, you use structured interviews, so you have a set of open-ended questions, and then what you do is you interview staff one at a time with open-ended questions, and you record the interviews. These recordings are then transcribed and anonymized, and then all of the transcripts are gone through, and themes and sub-themes are then developed out of that information. The questions that the staff were asked were around the formulation that was presented to them, how that formulation impacted their work and their emotions. And also, this research was done in April of last year. So this was right when the pandemic was really starting to hit, and right when all the restrictions had started coming in. So I did ask questions around the impact of the COVID-19 pandemic and how that work has affected people's ability to work at York House. Now, what we did in the study is I presented a formulation of a service user with challenging behavior. I presented this to small groups of staff ranging from 2 to 4 individuals per group. The formulation included a CFT component and a neurobehavioral component. The neurobehavioral component explained how the service user's difficulties developed and also aspects of what was maintaining their difficulties. The CFT component of the formulation described the service user's emotional dysregulation and how that presents, as well as the service user's overactive threat and overactive drive. I'm going to go into a little bit more detail on that in the next slide. The formulation also suggested ways in which the staff could change their approach to work with this particular service user to manage his challenging behaviors, as well as his emotional presentation. It was formulated using the 3 circles model that I've just introduced. It included history and background of the service user, and also different neurobehavioral aspects of the formulation illustrated the service user's neuropsychological deficits, general emotional presentation, and pre-morbid emotional functioning, and the changes that had been associated with his specific acquired brain injury. Again, all staff were in small group tutorials. This study did receive ethical clearance from both the University of York Department of Psychology Ethics Board, as well as the Disabilities Trust Ethics Board before the study began. All staff at the end of the tutorial were asked if they wanted to participate. Everyone said they wanted to. I think one person who said they wanted to couldn't find the time to do it. Staff were allowed to do the telephone interviews at work, as this is part of service evaluation. So this is the 3-circle model that I presented on the service user, and this represents his baseline presentation. As you can see, this is someone who has a very overactive threat circle. Okay? He was incredibly anxious. He was incredibly reactive. He would become quite irritable or quite nervous or quite frightened. And again, I conceptualized his presentation as one that is fear-based when he presents with challenging behavior. However, also note he has still a quite active drive. That drive included a lot of drive to just stimulate or avoid anxiety by environmental change. So being asked to move from one room to another. There was also sexually inappropriate behavior included in part of this drive component. And then also just frequent requests for food or drink in spite of having very regular food and drink related to memory deficits. Notice also that the soothing circle in this formulation is minuscule. This service user had completely lost his own ability to calm himself, to reflect on his own emotions. He just got caught in this big red threat circle. Now, this is another component of what I presented to the staff, and this graphic was part of the formulation in how I described staff should try to present their own emotions to this service user. Okay? In order to deal with his large threat circle, staff have to present as calm, soothing, and comforting as possible to him. The staff also needed to present with a significant amount of drive so that he didn't become anxious over his needs not being met. So if staff were able to be calm, soothing, but also motivated at the same time, that would, number one, address his issues, and number two, reduce his perceived threat. I also made it very important that staff consider their own red circle. Now, again, this service user required assistance of 2 for all personal care, and most of the challenging behavior occurred during personal care. It was very easy for staff to conceptualize how personal care can be perceived as threatening, especially when you're confused. So staff needed to be very aware of their own threat response when the service user was aggressive toward them. If they did get hit during personal care, staff had to try their best not to react in a threatened way, but to react in an understanding and comforting way in spite of the challenging behavior being directed at them. So we had a total of 9, and that sounds like a small number, but with this type of qualitative analysis, 9 is actually a good number to get an idea of the themes that are going to be generated through the questions. We had a good selection across the MDT, from assistant psychologists and ward managers to quite a few rehab support workers, therapy assistants, and a couple nurses. Again, these were individuals who all worked closely with the service user, and they had known this service user from 6 months to 5 years. So they all knew him well and had good experiences of working with him. these are the results. These are the themes that came out of the analysis. We got 4 superordinate themes and the varying subordinate themes. Now, I'm just going to talk through these briefly and try and give a couple examples of the things staff said under these themes. The first theme that came out was the reassurance of staff's feelings and work with service users. It helped staff, number one, validate their feelings. It's important for staff to know it's okay to be upset when you are threatened. It's okay to be upset when you have been hit. I don't like it when people try to downplay or act tough in a situation where you have been threatened or assaulted. And reaffirming the feelings of staff gives them a sense of competency in the work that they are doing. The next theme that came out was the accessibility of the formulation really helped staff understand the behavior and the service users' responses and their responses as well. They found the formulation very user-friendly and easy to understand. It engaged staff in the understanding, and the conversation with staff was very fluent and fluid when we were having the tutorials because it's an easy concept to understand. It also helped improve the staff's confidence in working with this particular service user and how to best provide support for the individual. The next theme that came out was just consistency in training and established practice supported natural interactions. And I think this is probably the most interesting theme that came out. First off, the consistency aspect of the training helped the newer staff feel supported and helped them feel as though they understood why everyone within the team was working the way they did. But the other thing that I found that was fascinating was this formulation provided a natural structure for staff to monitor and guide their own emotions and to guide their everyday interaction with all service users. So there was a good degree of generalization from this particular formulation to how they approach work with everyone. So again, I was very happy with that result. The final theme that came out were all COVID related. And I'm not surprised this came out as a separate theme because it wasn't directly related to the research question, but it was such an important point in time that I thought it was important that we try to capture what staff were feeling around the pandemic. And some of the themes that came out with regard to the COVID related questions were, first off, that the PPE, the masks, staff felt as though the masks were creating a barrier to positive interactions. And similarly, the restrictions made staff feel over-reliant on verbal de-escalation. Again, when working in a challenging behavior environment, you use a smile, you use a soft, calming face to try and decrease anxiety in another. That doesn't work with a mask on. And so staff had to try and verbally de-escalate more. And with service users with profound cognitive impairment, sometimes verbal de-escalation is trickier than just presenting a calming stimulus of a supportive person. The restrictions also, one of the themes that came out was it disrupted routine, which increased frustration in the service users and decreased quality of life. And again, I'm not surprised by this theme. When you have service users who have a structured routine, which includes going out into the community and practicing social skills on a day-to-day basis, and now they're only allowed to go shopping once a week for essentials, it is a significant change in routine, and it did impact quality of life for our service users. It's impacted quality of life for everyone. And I'm sure everyone sitting in this webinar, audience understands that. It has been, that is actually a discussion that many staff have had to normalize the fact that we are all in this pandemic together and it has impacted everyone. The final theme that came out was that staff felt that there was an increased dependency in service users on staff, which did increase the stress of staff. And again, all of these themes make a lot of sense. And are what you would expect. Now, some of the discussion points that I would like to make is, first off, the increased staff confidence through this type of formulation, where you normalize emotional reactions in staff, despite the challenging behavior. This will lead to better rehabilitation outcomes. And how it does that, there is a lot of research out there that shows, in general, staff across any service provision will try and avoid challenging behavior. No one likes to get hit, no one likes to get swore at or called names. So it's a natural human inclination to just withdraw from those kinds of behaviors. Unfortunately, withdrawing from challenging behavior can then reinforce the challenging behavior. And so when you give staff tools to work more consistently and more confidently with that challenging behavior, it makes staff more likely to engage, more likely to approach the suffering that someone is exhibiting, as a compassionate model describes. And therefore, you will have better staff consistency, better interaction with service users, and better rehabilitation outcomes. The next point is the overlap of the CFT drive and threat components with a dysexecutive syndrome formulation makes understanding dysexecutive syndrome easy for all the staff. It's really easy. Psychologists can get very wordy and get very complicated in how we describe things, but often complexity in how you describe something isn't going to get the points across that you need to get across to everyone, staff and service users. So this model simplifies dysexecutive syndrome by looking at it really through affective drive and threat imbalances. And the final point is the CFT-based formulation that focus on staff feelings gives them a sense of support. It generalized to how they work across numerous service users, regardless of the specific formulation. And that generalization and that ability to better work with the difficult emotions that come with the work that we do helps support staff and hopefully helps prevent burnout in the future. Now, what are my future directions with this study? Well, like I said, this study was done a year ago. I am actually in the process of, I'm about to replicate this study, but I'm going to replicate this study with two different groups. One group will be treated exactly the same as I did before. It will be staff giving a CFT-informed neurobehavioral formulation in the form of small group tutorials. The other group is going to receive the same information in a pre-recorded video tutorial. And the reason I'm doing this is I'm sure everyone understands how difficult it can be to get good staff training done and get information out to all staff. And so video working is something that we are all relying on more and more now. However, the evaluation of the pros and cons of video versus face-to-face tutorials hasn't been looked at, and it's never been looked at along these lines. So that is a study that I will hopefully have up and running by the end of next month at York House. So that is my talk. I will now say we're going to save questions for the end, but I'm going to hand over to Dr. Thomas Olympia, our consultant psychiatrist, and I will let Thomas take over now. Thank you very much.
Thank you, Mild, for a very helpful and sort of entertaining talk, which kind of clearly covers what we do, the basics of it, and the base of it, actually, like the backbone of it, which is great. Good morning, everybody. It's Thomas, and I'm the part of my talk is about describing two sets of information. One is the brain disorders, the brain injury, and then I hope to go into describing treatment models in complex brain injury patients. And I got a number of slides, but they're all available with the delegate package. So I might actually kind of skip through some of the slides quickly, but all the details are there. I thought it would be helpful for everybody to have more information out there that you can refer back to at your convenience. But thank you again for coming into our webinar today, and it's good to have you here. So starting off with my first slide, just trying to describe brain, as we all know, a complex system. So as the years pass by, our understanding of our own brain has got better with times. In the past, maybe 10 to 30 years ago, people talked about just the lobes of the brain, the primary function area, the associated areas. And now we know and understand there are a lot of networks within the brain which are relevant, and there are a lot of loops, functional loops. So the understanding of the complex, the framework of the brain is increasing, and that helps us to understand why some people after the brain injury present in certain ways, whereas with sort of a similar injury to someone else, it might be a different outcome. So so to two people having the same kind of impact or type of the insult to the brain may come out completely differently at the other end. So it's fascinating, and it helps us to sort of understand, and thereby looking into specific ways of supporting people and to make their lives better. So traditionally, we had sort of I wouldn't bore you with the details of the brain the structure as it is. There's someone saying that I can't hear. Is there any speech problem, or is there any audio problems? Are we okay with the audio problem? I can hear, I can see. Okay, well, thank you for confirming. Thank you. So the primary areas are controlling motor and sensory functions, and then there are the association areas. So traditionally we had the frontal lobe, parietal lobe, occipital lobe, temporal lobe, and each have their own function, and the audience is very well knowledgeable and educated, and I would not go into describing the basic functions of the lobe. And we also know that there are association areas. The association areas, that's a purposeful action. So a primary motor cortex will decide which limb to move. It know how to send the signal to the part of the hand to make it move. But the association area, which is adjacent to the primary area, makes it a purposeful, meaningful movement. So I reach out to a cup of water and drink. So it's the mechanics of it, and it's the sensory and sensible side of the brain, which the combination of which makes each of our day-to-day functioning and each moment of our life livable and meaningful. So coming to the large-scale brain networks, this is kind of from as the imaging got better, people are able to do sort of finite functional imagings, and that leads on to understanding there are the parts of the brain which are kind of connected with the white matter fibers together, that functions in certain parts of the kind of our day-to-day functioning, and they are very relevant and important. You know, there are sort of, in terms of the networks, there are three main networks. There's a salience, then the default, and the central executive. Default being when we are in a bit of an idle position, possibly during this webinar, we're going to be, most of us are going to be in a sort of spending most of the time in the default mode, occasionally sort of sort of going into the central executive function, and then the salience network is what that controls that switch. So it's a default is mainly when we are idle, the brain's got kind of background activity going on, and central executive is when we're acutely focusing on some relevant information and trying to grasp that, and the salience network is detecting what's happening and then switching it back and forth. So it helps it all nicely regulated. Then we know there are lots of loops. So we increasingly understanding there is a body movement loop, there's an oculomotor loop, and the frontal temporal frontal loop, and a limbic loop. So this is essentially three parts of the brain which forms these loops, which is part of the cortex, part of the basal ganglia, and thalamus, with all the input from other places. And just next slide, going to the body movement, it selects and stops specific movement. So if I know that I need to sort of go and make my tie tidy, and then I need to know there are specific movements I should do. But if I'm all over the place, I won't get to do my tie. So this loop actually kind of starts very specific movements and make it more finite, so that we do kind of very carefully crafted movements with our hands and legs and eyes, and that we are able to do that other animals could not do. So that very specific, very sort of creative, like imagine an artist drawing picture. So they're very careful movements with the hands, and the footballer kicking the ball straight into the post. So that's again the finite thing. So that very careful selection of it, and to make it very precise. And when there is a disruption in that circuit, that's when we have conditions like Parkinson's disorder, Huntington's disorder, and that could be because of the chemical imbalance within that network which controls that finite movement. Similarly, for oculomotor loop, does that same for the eyes. Prefrontal loop, very important for what we do in our clinics. This is executive function. So this is kind of the stopping, when to stop, when to think, when to start thinking and acting on certain ideas, when to stop thinking about certain ideas and move on to the next one. And then situation has changed. Suddenly we change our own perception about it and make a completely different set of decisions. And once we've made a decision, to carry that through. So that's sort of very clear executive function with that loop controls the executive functions, and that's implicated in brain injury, ADHD, impulse control disorders. And similarly, the limbic loop, which is important in anxiety disorders, mood disorders, and again implicated in brain injury, which controls our emotions, which controls how we regulate emotions. We can be annoyed, but we can hold on to it. We don't have to immediately show that annoyance if something is not working out, whereas some people, it's not possible, and then people lose the control on the situation, either get the floods of tears or aggression or threats, and behaviors follow. So again, that finite control of behaviors. So these loops are increasingly being understood as very important in the areas of brain injury, and the neurodevelopmental conditions and other associated conditions. And I'll go on to sort of describe how how those sort of networks are important in the treatment as well. Just a kind of a slight stretch of idea from here. So these the loops do have their input from other areas of the brain. So that the basal ganglia, now we know previously considered almost like just a part of the brain 30 years ago, but role of basal ganglia is increasingly being kind of understood as a central kind of a command, as the microchip that rotates everything and makes it run smoothly. So it gets input from our fear centers, our memory centers, our reward centers, and so the drives to sort of either go and achieve something, do something nice, or drives to do something not nice, or to drive to run away from a threat. And as going back to Miles's talk about the balance between the threat and the drive, and what drives you to people to do things which are productive, positive, as opposed to unproductive and kind of negative. So that sort of a balance. The whole thing is controlled by the processor, which selects which input to take, which input to execute. So that's the process there. Going on to describe traumatic brain injury, we know this definition. There are a few definitions floating about, and this, for the sake of the presentation, we putting this as the Department of Veteran Affairs in US, and we all know what that is. Headway, local data. As we all know, the incidence of TBI have been increasing. It'll be interesting to see what the impact of lockdown's been on. So we are all kind of keen to find out the post-lockdown data on TBI. So we know that until then, the numbers have been increasing, particularly in males, but the female data have also been showing that the numbers in female, the brain injury prevalence has been increasing. Again, we know the classification of brain injury severity. The more consistent and reliable indicator is the Glasgow Coma Scale at the time of the incident and at arrival to hospital. And based on how someone has scored on Glasgow Coma Scale, it gets sort of classified into mild, moderate, and severe. Role of post-traumatic amnesia is also important to consider and sensitive, but at the same time, sometimes with lots of neurosurgical procedures being done and people being in ICU for a long period of time, that data become less reliable to taken into account. And quite often in imaging, the brain imaging, mild brain injury, quite often it's normal. But you can have moderate and severe with absolutely normal imaging coming back, at least initially, and until you do very specific functional images, you might not see all the changes that's happened. But quite often there are very significant changes in the brain that are picked up by the initial MRI and CT. The types of injury, as you can see there, broadly can be classified into a contact damage and internal damage. So the contact damage, particularly sort of the brain pushing against the bony structure, the wall to the brain, and having contusions in parts of the brain which it presses against bony structures of the skull. And there are certain areas which are particularly vulnerable because they are sitting sort of so close to these bony structures, and in case of a shear force or a fall or whiplash or countercoup, those in the areas of the brain are particularly more susceptible to be injured. Whereas the internal damage happens within the tissue of the brain, whereas when the brain gets sort of shaken about and thrown about, the structures within that get sort of torn, and there are particular areas of the brain where the boundary between the gray matter to the outside, in consider the cell body, the neuron cell bodies, and the white matter, which is basically the fibers, the axons that goes from the cell body to the end organ and spinal cord. So the junction between the gray matter and white matter, that's where the most vulnerable place for internal shear injuries, which lead to micro hemorrhage and particular hemorrhage and destruction of the fibers, leading on to diffuse axonal injuries, and that can be widespread. There is sort of even classification of diffuse axonal injury based on the location and the severity and the number that it has, but they have profound effect on cognitive and neuropsychiatric presentation, which we'll be coming on to now. So this is the, showing the areas of the brain which are more susceptible, the part of the front, the more evolved part of the brain. So as in the brain evolution, we have the back of the brain, which controls the respiration, our heart rate, our fight and flight, and then we have more sensory areas and balance areas on the side, and the more evolved the areas of the brain, which is controls the executive function, our personality. That's the area which is most susceptible for an injury, because they are kind of really wedged between tight bony structures of the skull, and with it doesn't take much to have a damage there, and the effect of that, those damages can be profound and long lasting. So not two injuries are same, even for the same person, and it's a situation of a unique set of forces acting on a unique brain. So what you get as an outcome is quite different to injury and to person. What we know is like it tend to lead on to significant changes in cognition, emotion, and behaviors following traumatic brain injury. This is a cascade of changes that happens within a brain cell that is injured, and eventually from the insult to the destruction of the cell. Come back to diffuse axonal injury. It's usually found in after closed head injury, where that shear force shear the brain's the matter from the cells to axons, and usually associated with the loss of consciousness, and it is associated with significant cognitive and functional impairment. Some pictures of diffuse axonal injury. You can see the white spots here on the image on the right side, and also on the left, the initial picture shows. So they are kind of very minute, and usually picked up by MRI. Sometimes you have to do the contrast enhancement, but it can be easily missed in the first CT that was taken. That will come back as reported as normal, no changes found in the initial CT, but later on we see patients start to suffer from significant cognitive and other difficulties. As we understand more, the brain injury is usually an effect of a localized injury and the network disruption. So we were talking about the network disruption previously, whereas there are changes that happen to the networks and the loops that we described earlier on. You could have a localized injury, but the part of the network that controls a whole lot of other functions are also disrupted because of either the direct injury or the sheer force of injury, or the diffuse axonal injury that has happened because of that. So what we get is there's a combination of someone with a deep penetrating injury to the temporal lobe, and that affects the function of the temporal lobe. And then because the person was thrown about, they get other shear force injuries, and that combines as a network disruption. So what we tend to see is the eventual outcome or the presentation can be disproportionate to the injury that's reported in a scan. So this is what people encourage. You never go by a scan, you look at the person, because scan can be deceptive, and unless you have very specific, clear, detailed MRI images with functional component added to it, that you don't never get a fuller picture of the extent of the damage that's happened to the brain. So it's very important to establish and try to correlate where it's possible with the image, with the findings, observations, and any neuropsychological and functional real life tests that we can do. And the range of symptoms that we tend to see, physical symptoms to do with seizure, anosmia, motor, vertigo, and cognitive symptoms, a range of symptoms from memory, new memory formation, and neuropsychiatric presentations, including a range of behavioral presentations, mood, anxiety, PTSD, obsessional symptoms. So it's the whole combination that we tend to get. As we know, outcomes in mild TBI, full recovery is possible within months, but with repeated mild TBI is sort of a accumulation and sort of add-on effect, which can lead on to long-term impairments. Whereas moderate, a few months to a year, with severe mostly residual cognitive and neuropsychiatric presentations are expected, but still full recovery is possible. The usual presentation we tend to see, this is kind of a circle of sort of confusion, executive function deficit, cognitive and neuropsychiatric presentation, and a natural progression. The easiest thing that gets better is that confusion lifts, that level of post-traumatic amnesia state, that sort of delirious state lift, and then what we tend to see are someone with impairments in cognitive function, executive functions, and a range of neuropsychiatric and behavioral problems. So the nexus of how can we try to unpick and explain certain behaviors we see in people with complex brain injuries? So the more we understand it, it is a combination of pre-morbid conditions, so how people were before the injury. So it's the person, the brain, the injury, and what happens after that. That is a combination of that almost defines each presentation and how each symptoms and how someone behaves in that context. And in that, previous traumas are important, and some people do sometimes, and quite often in complex cases, you hear people who have had one or two brain injuries in the past already, and they got better, but went on to have a further severe brain injury. And then pre-morbid personality is important, how they manage to deal with stress, how they manage to kind of, what were their kind of predisposition, their habits, their safety, and previous sort of substance misuse, crime, and mental health disorders, and mood and anxiety disorders, psychosis, all that are relevant. And as we're describing in the factors relating to the injury, where the injury happened, the network disruption and the loop, the disruption of the loop, which may be disproportionate to the actual physical injury happened to the brain, and the kind of the confusional state, the memory state are relevant consideration. And what happens after the brain injury? So in what setting they go to, the structure of it, the scaffolding, the availability for treatment, the availability of the adaptive technologies and their ability to rehabilitate. So that is important. So that kind of combination of these factors, and if there are someone with previous trauma, with history of anxiety, with severe network disruption, if they end up in a setting which is not helping their presentation, they're likely to be presenting with a range of symptoms that can't be managed in that setting and would need more attention and input. So it's kind of a scatter of presentation of a range of symptoms that we tend to see, from memory problems to cognitive problems, self-awareness difficulties, executive function difficulties, challenging behaviors, aggression, and so on and so forth. Again, to list out some of the common network disruption disorders. This is arising from diffuse axonal injuries, which are very common. And we see a range and combination of these presentations. People with emotion regulation issues, motivational issues, so they can't start things, apathy, their emotions blunt, their attention concentration is impaired, and energy and fatigue issues, sleep-wake cycle issues, clear executive functional deficit, and impulse control issues, and self-awareness difficulties. This is now, we understand, is partly sort of controlled through this network, whereas having a memory of ourselves, a memory of our own function, being able to perceive things from outside and to compare it, that function is important in self-awareness. And people with network disruption, the disorders, are likely to have self-awareness difficulties, where people might say, I'm fine, despite having significant memory and cognitive difficulties. Again, listing out some of the neuropsychiatric presentations: major depression, mania, obsessional compulsion, PTSD, psychosis, and personality change. gone to a little bit more detail about the personality change, about 30%, apathy, motivational difficulties, affective levity, which is again common, and sudden variation in people's ability to control their emotions and respond. And aggression, so this can be spontaneous aggression, or aggression targeted towards specific people or settings, and what we tend to sometimes see as an intermittent explosive disorder, IED, where there is severe discharge of aggression that sometimes people don't even have a recollection that they have done that. A quick run through the hypoxic brain injury is, again, it's a different type of brain injury, and the range of symptoms there are a range of kind of motor symptoms with movement disorders, sleep-wake disorder, changes in consciousness, and executive function and memory impairments there. Cerebrovascular disorder, again, listing out a range of symptoms that we can find. Depression is very common after cerebrovascular disorders. Apathy and motivational disorder are common, same as impulse control, irritability, anxiety, and speech difficulties and swallowing difficulties, as in the pseudobulbar. Autoimmune encephalopathy is relatively rare. Most there are, we're finding kind of rare sort of disorders, but anti-NMDA are commonly present in psychiatric settings because the initial presentation in that disorder is a psychiatric presentation. So people could be missed unless someone go and do a specific autoimmune testing. Whereas with other autoimmune disorders, there's usually seizure or myoclonus or other motor symptoms that comes before the psychiatric symptoms. But with anti-NMDA, quite often it's the other way around. So it's worth mentioning for all my psychiatric colleagues. Now, coming to models of treatment in brain injury, traditionally you can have a pharmacological approach or a non-pharmacological approach or a combination of both. And treatment settings are sort of mild to moderate severity of the brain injury, commonly sort of community-based. Severe can be community-based, it depends on the presentation, and with severe with complex presentation, it's usually starting at least with the inpatient setting leading on to the community setting. In the non-pharmacological approach, it's mainly behavioral approach. You must have heard kind of use of sort of models like positive behavior support, quite popular and useful in learning disability. But as Miles talks in his presentation, that people with complex brain injury just need a more in-depth kind of learning process in a structured environment. So a targeted PBS might not necessarily be applicable or be useful in this setting. Either way, the holistic approach addressing both the lesional and the psychopathological, which is basically you address what's caused by the part of the brain that's affected, but you also look at the person, you look at their context, and you look at their environment, look at their past, look at their previous presentation, look at their usual likings, dislikings, and what's changed. So the fuller context of it, and in its entirety, you look at it, and that's what you need to address. And in traditional neuropsychiatric settings, there is quite a lot of emphasis on use of medication. So, and that in a setting where there is a heavily medication focused, you see medication suppressing learning and the ability to learn new things, especially antipsychotic medication and benzodiazepine, quite frequently used in settings which are predominantly medical focused. So that suppresses people. It's really good for behavioral management because you see great changes in the aggression scale. People just calm down, but it just keeps them locked in almost, and almost prevents an opportunity to learn, because antipsychotics affect sort of people's ability to learn. It affects executive function, memory formation. Similarly, benzodiazepines does the same. in memory formation, and it can even wipe off available memory if used inadvertently. So it's significant effect on people's ability to move on, to learn, and to in their quality of life. But without the pharmacological intervention, some other complex cases could not be addressed, and the people are not ready for rehabilitation, and that limits what they can do. So essentially, we need a balance, and that's what the model we are talking about sort of encapsulates and addresses. So there's the balance between use of the medication, the medication interventions in the right way, with the backbone of a behavioral, neurobehavioral intervention, as Miles described, with the right sort of framework, which includes the compassion focus approach, so that people get the best benefit out of that. And in the holistic rehabilitation, the environment is important, the compensating scaffolding, the structure you can provide for people, so that they have more support to start with, and then they get less and less as they gather information, they gather skills, and they rehearse and then learn through that process. And it facilitates learning in a very compassion-focused and acceptance-focused environment. With the medication, you are preparing people for rehabilitation, you're stabilizing the turbulence, the kind of the behavioral problems, the challenging behavior that's happening, and you're increasing their engagement and their ability to learn and adapt. And going back to the two slides, just for us to remind ourselves about the complexity that it develops. So with the Neuropsychiatry Plus is the use of medical model at each step of rehabilitation, in the stabilization, getting people ready, and in the active stage of rehabilitation to enhance the rehabilitation, enhance learning, and at the time of discharge to sort of facilitate that. So this is, in some ways, an inverted model of the normal neuropsychiatry model, whereas a normal neuropsychiatry model would be heavy emphasis on the medication with psychological and behavioral input as a sort of a secondary step, whereas this is kind of more on the use of the right pieces of medication in the right way to support the rehabilitation. It's very clearly sort of well represented MDT, that's clearly needed. And just to kind of mention about the milder presentation, so you would do sort of more support around the motivational enhancement side of things through an acceptance and commitment focus. But what we tend to do in our clinic setting is more of a complex presentation, and for that, as we heard earlier on, what it holds together is the compassion-focused therapy and neurobehavioral model, and within that we have the right use of medication, the use of goal-directed behavior training, rehearsal, learning, and metacognition, where this is use of kind of available kind of resources to make changes in other areas, actually. So that's the sort of metacognitive approach has been clearly used there. And the Neuropsychiatry Plus focus on from turbulence to engagement, so people who are not ready for treatment and you manage the turbulence. So wherein you would have a specific medication and set of medication to get them ready for rehabilitation. Any use of benzodiazepines is limited. Any use of antipsychotics is again very limited there. And in the active rehabilitation phase, you actually increase the chance of learning by sort of neurostimulants, cognitive enhancers, and medication that works on our internal regulatory system in a very specific, targeted manner. So that combines with all the other interventions and behavioral techniques, the compassion, the interaction with the environment, the rehearsal, the feedback. So it works seamlessly with whatever that is happening in the active rehabilitation, but without impairing it. So it is the medications and the medical model is used to enhance a learning process. The emphasis is clearly on the enhancing the learning process and ability for consolidating the gains rather than suppressing people or keeping them quiet. So it's used in a completely different manner to emphasize the progress and the long-term sustained kind of gains that people could take with them to the next stage in the discharge phase. So for that, we devised our own turbulence to engagement scale, which is a 36-item scale, which looks with 6 subsets. And so everybody has a specific check on those 36 areas of their behavior, and specific interventions are planned, which can be environmental, medication, and these are the 6 areas to do with emotion regulation, executive function, orientation, challenging behavior, mental health, and self-awareness. So these areas are looked in detail. So each of the 6 items has further 6 subsets and information, and their the progress is detailed out and analyzed through kind of week-to-week progress. And you would see people where people lie, so you would see people more turbulent on the red and more engaged. So and as the treatment progresses, you would see more of that green taking over the red. So there's more engagement and less of turbulence. And a treatment priority is kind of to address the confusional state, because if someone is very confused and delirious, they're not going to take anything on board. So you try everything to make sure that they are less confused through environmental adaptation, use of medication to reduce that. Surely you need to address the communication, language difficulties and impairments, because without that, they're not able to communicate properly, and reduce challenging behavior, address the comorbid disorder, executive function improvement, memory deficits are addressed, and addressing self-awareness is the hardest bit, because people could make a big progress and still go on to say, I'm fine, nothing happened to me, I'm good. So that can be the most challenging, and that has the most important implication in people moving on to a setting where you would expect them to be more independent, because they would want to be aware and utilize the right setting and the right help, and they need to initiate and accept what may be available for them in future. So from dysregulated state to an enhanced self-regulation is what we are trying to achieve here through this Neuropsychiatry Plus model, which works well with the backbone of the neurobehavioral model, enhancing learning. And from a dysregulated state, people go through stages to get to an enhanced, self-regulated, consolidated progress and good outcome. So we're coming to the question and answer session, and I can already see questions popping up on the side.
And hi, everyone. Welcome back. I was going to say, I see that I've got a question from Tom. I'm going to go ahead and try and address that question. Now, Tom asks that he's working with individuals with orbitofrontal damage, where one theory of disinhibition is that they've got an impaired ability to anticipate negative consequences or threats, and that leads to an overactive drive system, which then manifests in challenging behavior, which in turn it turns into threatening behavior to family and staff. How would I formulate that using CFT, and how might I intervene? Not an easy question, but also, oh yeah, I'll get to that other question in a minute, Liam. But yeah, for that question, my first question is not enough information for me to actually do a proper formulation, but I would state a lot of it will depend on the individual service user's level of insight into their condition. I'm going to assume by the diagnostic entity that the person is diagnosed with, that they don't have insight into the impact of their behavior on others, and they are likely to not have insight into their own issues with drive. So therefore, my formulation of someone presenting like that would probably be more about understanding the overactive drive component as leading to the challenging behavior. Now, there might be some aspects of that drive that can be intervened with appropriately. There might be other aspects of that drive that might not be appropriate. So, if the drive is food based or fluid based or environmentally based, you could probably put in good behavioral or structural interventions around that. And again, this is going from a CFT formulation to a neurobehavioral intervention. If the drives are very sexualized, then that actually is something that might be much more difficult to address. And without knowing the individual, knowing their presentation, and having a good, complete behavioral analysis of their presentation, I wouldn't even want to guess at how I might go about intervening with that. So, could you use a CFT based formulation to describe that presentation? Absolutely. Could you use that formulation to describe intervention points? Probably, but I would need a lot more information to try and come up with an intervention along those lines. Hope that answers that question, Tom. And then the other question that I had up above was from Leanne, and she asked if I was able to give an example of how a CFT approach can help address sexual dysfunction and disinhibition within couples. Now, I'm going to assume that that is within couples where one of the individuals has an acquired brain injury. And again, interesting question, appropriate question, without enough information about the individual with the brain injury and the dyad, the couple. I don't want to give any hard advice because I don't have enough information to give sound advice. I would say you can formulate sexual disinhibition as a drive related component, depending on the kind of insight that person then has, and depending on the relationship, you might be able to use a simple formulation to get that person to understand how their overactive drive translates to threat in their partner. Maybe. You also might be able to try and get an individual to reconceptualize sexualized drive instead, and instead of it being a sexualized drive, try and reframe that into a companionship, affiliative drive. And affiliative relationships are actually soothing. So there may be something that you could do to turn that drive into an actual soothing intervention. But again, without actually knowing a lot of details, I can't give any very specific advice about that one, Leanne, but hopefully that might have given you some ideas. And if there is a member of if you are CFT trained, or there is someone CFT trained on a team that you work in, this is something that you might be able to talk about. And again, one of the things I love about a CFT three circles model is you can formulate the service user, but you can also formulate how the behavior affects others and formulate their reaction to behaviors. Sometimes that might be able to be used to help a service user develop insight into the impact of their behaviors on others. And I think those are the two questions that I had. And then the next question I see is from Joanne. Hi, I am an OT and was wondering what outcome measures you would use to document progress or the lack thereof. Oh boy, we have a lot of outcome measures at York House. Now, um, uh, the outcome measure that Thomas was just talking about, the test, the turbulence and engagement scale, is one we are currently piloting at York House. And we developed that scale because we wanted to find a way of knowing when individuals go from a stabilization period to an engagement period. And the Thomas and I did a lot of reading around the literature on this, and there are lots of measures of turbulence and engagement the psychodynamic literature, we could not find any examples of turbulence or engagement in a neuropsychiatric or in a neurobehavioral population. So, so yeah, we're in the process of developing an outcome measure to look at that specifically. The other outcome measure that we have added specifically for the change to a neuropsychiatric model is the TOM, the therapy outcome measure. And what we have done with that measure is we are using the brain injury specialty scale, and we have also developed our own neuropsychiatry plus scale, which is going to be a bespoke scale that we use within York House, which incorporates three different other subscales looking at the psychiatric, the cognitive, and the behavioral presentations and how those change over time. If you know about the TOM, you'll know that it is an MDT rated outcome measure. We are doing this measure quarterly, so with admission and then within the 12-week review process. We have a ton of other outcome measures, but those are the new ones that we have introduced to evaluate the model. From next question, any advice on how to manage challenging behavior in TBI patient which has significant variability related to her menstrual period? Thomas, that
Possibly, yes. Yeah, possibly I'll take over. Yes, thank you for the question. So, I mean, without sort of the context of whether it was a mild injury, the other impairments, but just by going by that piece of information, I would imagine someone who has a sort of mild to moderate severity of injury and has other challenging behaviors and mood issues, or they might not have, or this may be their specific or only difficulty. What I would sort of look at initially is that have they got a history of sort of menstrual related PMT related mood disorder? Have they had a history of mild bipolar disorder? It's a moderate to severe TBI patient. Yes, thank you, Greg. So have they got a history there in terms of either as a PMT or history of a mild bipolar disorder, family history of bipolar disorder? Important to consider because, as we know, the sort of cyclical mood changes are sometimes quite sort of disguised as bipolar, sort of PMT, but it may be bipolar disorder and that. No known previous issues, yes. So if it's sort of related more to the post-injury setting, it may well be kind of the situation where they are kind of going through a natural, stressful kind of body, going through a stressful situation, and that their inhibitory centers are overwhelmed very quickly, and these behaviors comes out. Important thing to consider is the post-traumatic epilepsy, which again can be disguised as an absent seizure or an episodic discharge, because menstruation increases the risk of epilepsies. Obviously, if they've already sensitized with the post-brain injury, so that might be something to rule out. And again, post-brain injury mood disorder. So is it a combination of emotion regulation issue or a post-brain injury mood disorder or an epilepsy sort of disguised as challenges? And how can come across patients having psychotic? Okay, it's a different question. So what I would do is to sort of have a bit of an assessment of what might be at play at that time. If they are not in a mood stabilizer, and again, that is considered an accepted intervention. So is the SSRIs for aggression, and it helps with PMT, helps with the post-brain injury aggression. So it's worth trying to start with something like a straightforward SSRIs leading on to further assessment. I mean, I think at that point to have epilepsy ruled out would be really good, and trial of mood stabilizer would be good as well. So I have another question here. Have you come across patients with COVID-related psychotic case with ABI? So COVID-related psychotic cases. So we're sort of in the post-COVID world. Now the understanding is that COVID does not directly affect the brain, but people who have the brain injury most likely because they have had a terrible time with their heart lung functioning. They've been in the ECMO. They've been in the ventilation. Some of them had kind of sort of minor strokes. So the brain injury is sort of a secondary to other metabolic and other hemodynamic factors that's happening to people with COVID and hypoxia, rather than a direct insult of COVID on the brain. But that may change when we have more studies coming out. But surely I haven't seen a clear psychotic presentation as such, but we have had patients who have had COVID, and we have had referrals from other settings where people have had a severe sort of a heart-lung compromise and hypoxic injury because of that. So we tend to see more of hypoxic injuries and anoxic injuries post-COVID, and that tend to be sort of related to how they would normally present. But with the added fatigue, the added compromised lung function, and it becomes a completely sort of slightly different sort of management than someone with a pure hypoxic injury. Sorry if that answers your question.
And I'm going to make this the final question, if that's okay, Leanne, because we were supposed to go to noon, and it's about noon. I'm fine with going a bit longer, but this is from Leanne. What outcome measures do you use, if any, around sexual dysregulation? She's a nurse practitioner, but works within private case management. Your questions are because MDTs seem to swerve around any issues sexual, unless they are potentially criminally offending. And as such, the dominant issue for communities, for singles, and those with partners post-TBI. I don't know. We have outcome measures that have sexuality as a small component of an outcome measure. We do behavioral analysis where we look at frequency of sexualized behaviors, and we would look at frequency of that changing over time. I do not have in our service any specific outcome measures around sexual dysfunction or sexuality. I will say I understand why MDTs avoid this issue, because it can be an issue that is, number one, it's very private, and number two, it's something that a lot of people are uncomfortable talking about. It is something that we do address on an individual case-by-case basis. Again, we always take a holistic approach. When the subject of sexual relations come up post-brain injury, it will depend on the individual. It will depend on the relationship they may be in. It might be a risk. It might be a return to normal functioning. Again, it's not a question that I could answer in a general sense. It's a question that I would have to actually answer in a specific case-by-case manner to give an opinion on it. And then from Claire, sleep or lack of sleep can impact on an individual's engagement. In respect of stabilization along with CFT, fear of sleep, or more so, might not wake up. Any thoughts on balancing an individual? Ooh, fear of sleep. Well, yeah, it's not a fear of sleep, it's a fear of dying while you're asleep. And I think that is actually something that you could target a bit more specifically. And again, it's going to depend on the level of insight that individual has as to what approach I would take with that. I might not take a CFT-based approach with a specific question like that. I might take more of a CBT kind of approach with something specific like that. But again, I'm really sorry I can't give you an easy answer to a complex question, but I would need a bit more info on that. And again, if you have any further questions, please feel free to give us an email. Thomas and I will be happy to get back to any specific questions you might have at a slightly later time through an email correspondence. And yes, the slides and Q&A will be recorded and available to everyone. So again, thank you all so much for your time. Thank you all for attending. And yeah, again, thank you. And it's been very nice giving this information out to you all.
Thank you, everybody. Thank you. Have a good afternoon.
Thanks, everyone.